wire.
İyi.
Because the proximal segment of the stent is not occluded, and I think the ostial segment, I mean, but we are trying to go there with a regular worker's wire. Did you manage to go to?
We have a little bit supporting problem, and I want to switch it to polymer jacketed wire with PI 200 because the angle of the proximal part in stent area to GN2 is not acceptable, and the wire crosses the subintimal space, and I will try the polymer jacketed wire to crossing in there.
Okay.
The good thing, I think the good thing for this case, there is still some segment open in the proximal stent, and but the downside is the coaxiality of the guiding catheter is a problem.
Yeah.
And also there is a big side branch take off the stent, so to control the wire is of some difficulty, like what we see. That I saw that Dr. Oren just rotate and control the guiding catheter, the AL1. The AL1 catheter, which can give a supportive, give a good support, but there are some difficulty for it to be coaxial. Bias, and so I think GN4 must be one of the options, but how to shape the wire and how to control it is of most important.
Just a comment.
Once, yeah.
Oh, sorry.
Go ahead, please.
Because here your guide wire is moving like you are already not in the vessel architecture. So I'm not sure that from the start you are inside the outside the strut. You see, because it needs to be.
I think this is side branch.
It's not right.
Yeah, but you see your wire is too free from the start. So the wire needs to have some resistance of constriction inside the CTO body, because here if you are so free, and you see sometimes the wire is buckling like a knuckle, so it means that there is some space, so you can't be inside the stent from the start. So just careful about that.
Kohan, this is a time where you might want to look in another projection, because yes, the body of the wire was too free initially. This looks much better.
Yeah.
Mihailo, you have a comment, and I also want to ask you about your experience with HDR for instant CTOs. I have no.
I just wanted to mention that, like Dr. Avram said, I think that first of all, the microcatheter and the wire is like floating in the air, so it's not fixed. I would be very careful not to maybe penetrate some side branch, because I think the microcatheter and the wire is not in the architecture of the stent. This is some side branch, in my opinion, from the beginning. So I would check for sure in REO and take a quick shot. And when I'm inside the stent strut, I wanted to mention one non-conventional way to do it, like go intra-stent with for example, Gladius MG traveling knuckle with a dynamic tip load playing with a traveling knuckle and go further. And also we talk
about. Check the right side.
Yeah, we talk a lot about HDR, hydrodynamic contrast recanalization technique nowadays, and there's some people likes it, some people don't, but I found it particularly useful in instant stenosis. So if you are intra-stent between the stent strut, it is, I think, very good solution, and it helped a lot of cases for me because
That's better.
you give a small amount of contrast and you define your proximal cap, you define some loose tissue channels.
And then again, left side.
And there is no harm from HDR in intrastent. You can do big dissection. You cannot make storm cloud dissection and so on. So the HDR technique from instant CTO is particularly useful. I think this is most useful thing for HDR in my practice. Not so native, but I think this is the side branch. This is the side branch all the time.
右边照个影看一下。
Angajmanı bir daha bir yapalım. Bir daha kurtul da
我没看到哎。
As you can see, Ahmet, there is problem with going wire with it through vessel architecture. It seems like it is in the architecture, but it is going somewhere different, and we didn't realize any kind of, side branches over there. For sure, in my opinion, the stent is not well opposed to the vessel wall, and there is some kind of gap between the vessel wall and the stent, and the wire is following that path through the subintimal space, and we have problem with engaging to the coronary artery because of the osteostratus that are protruding to the aorta. So now Korhan has a better position, and he is trying to feel this proximal cap actually, because the wire is going outside the vessel, and we cannot feel the proximal cap when we are coming with the wire at that point. So do you think this is a better place, Korhan?
Yes, I think I engage it to the proximal cap, and I am instant localization now, but I have a problem about the microcatheter crossing at the proximal side.
Maybe
But
we need
maybe-
to start. Is your wire going further, Quran? Because this is a much better position indeed.
Yeah.
I think it is in the beginning subintimal, substent, and
That might be a
inside the stent.
possibility.
Yeah. So because the microcatheter is not going forward, you see that he's bending. He's bending as there. We will understand that with IVUS actually, whether we are now, we have a nice progression.
In
We
my
are inside the
opinion,
stand, yeah. This is
first
a
of all,
polymer
maybe
jacket,
you
and
should
one-
working with ostium to make a guide, stay properly, and then catheter should go further. And
Maybe,
angle,
but
it
now
was,
the wire
you
is
can change
advancing.
the angle.
The wire is advancing, but the microcatheter is not advancing. You see that? When he is giving pressure to the microcatheter, the guide catheter is going down.
Make a
of the
small
ostium.
dilatation.
Maybe. But we
Ostium.
need some kind of
Put
wire
very
advancement
properly.
at that point.
We must be very careful. There could be some possibility the wire at the orifice of the stent just go the outside stent and cross the cell into again the stent. So once we go this way, we may risk to collapse the stent.
We should check.
Maybe check in different projection.
Yeah, we are totally sure about that. We are
We should check.
out.
There's a
check
lot of
stent,
resistance
outside
of the
stent, and inside the
microcatheter.
stent.
We should check in different situation.
Oh.
Position. We should check that why in
Mustafa,
different
We are
position.
sure about that.
Mustafa, we're trying to be
Now,
helpful
on the
here.
side.
We should check.
And
Excuse me?
we're trying to be helpful here. And this is going to be,
We should check.
you can
in
battle like this
different
forever.
Position. Not just
What
this
I would
position.
do is, I would leave this wire, I'd actually send it as far as it will go to enhance support to some extent. Get my microcatheter out, try to use that wire for better coaxiality, and wire the vessel again from the beginning with a different microcatheter and wire. And I would actually use the workhorse wire for that initial part of the stent until you face resistance. You don't want, there's an open part, and probably there's a lot of disease over there. So pre-dilating it is not a bad idea to help improve your engagement on the whole. But this is starting to look like you'll battle for a long time with limited progress. Alex, how would you move?
tekrardan
Dostlar,
angaja olalım diye
You're totally
söylüyorlar.
right.
Öyle yaptık abi,
So-
bir yerde attı aslında.
If your microcatheter is not following the wire, most of the time it's because you are outside the strut.
Sorry,
So, and the
pressure
wire, I think, went
is low,
start
lower
out
than the
and
beginning.
went in, and then it was very good because the track of the wire was perfect. But the microcatheter is not following because of this track inside, outside the strut. So for sure, your proposal was very, very interesting, and I think I will do the same.
So now we are trying to engage to the coronary artery in the second time. As you said, it is not so easy to engaging to that kind of a coronary with a 7 French catheter, because the size and that's better now. It looks better now. It's
I am not sure. It is at the conus branch maybe.
Huh? Let's see it.
No.
Just
Not that engaged.
While our service is still on the go, let's go to the cath lab of Foshan First People Hospital, and please welcome Professor Dr. Chen Yong, Chief Physician in West China Hospital.
Okay.
Diğer hastaneye.
我们正在做哈，
o telle uğraşma. O polimerli tel. Normal şeyle. Bak ilk başta gittiydi ya.
陈勇
Ben sana workhorse vereyim.
，Dr. 陈勇
Tamam
，Can you hear us？
哎，声音能不能给我开大一点？我听得见，但是声音很小。
声音开大点。
Okay. Well, we can hear you very clear.
Okay, I can
How's
hear you.
everything?
Okay.
Can you please introduce the case first?
Okay. Please, Dr. Wu, introduce the case.
Okay. Good morning, everyone in the conference room, and very happy to be present this case here. And next slide. And this is 14 years old male patients with hypertension, hyperlipidemia, hyperuricemia, and present to our hospital with chest tightness and dyspnea for 2 months. We have done some routine tests for this patient, and troponin is negative, and BNP is slightly elevated, and creatinine is within normal range. Next slide. And echo structure is normal, and LV systolic function is normal, and we can see some anterior wall hyperkinesia and septal hypertrophy, and which is consistent with his hypertension history. Next slide. And this is the patient's ECG, and we can see some O-infarct sign on the V1 to V3, suggesting he had a MI history. And we did an angiogram for this patient, and this is IO caudal view, and we can see that area was occluded, total occluded in the proximal segment. And area okay. Previous slide, 前面一张. Yes, the aerial cranial view suggests that distal vessel is relatively healthy. Next slide. And this is RCA view, aerial view, and we can see some very good septal collateral from the PDA to the mid-LAD. And we estimate the total length of the CTO body is around 20 millimeters. Thanks.
Okay, thank you for the introduce. Let's us see the angio of today. We have 2 angio. Next one. So how about this case, Dr. Yang?
Sorry, Dr. Young had to leave to the hospital. He has an
Okay.
emergency, but we're following you and we're looking at your setup shots.
How to do this case, to your opinion? Antegrade or retrograde or ADR?
Okay, so can we look at the previous angio, the previous one? Only the previous one?
Previous. Okay.
Yes, perfect. So here your antegrade guide wire is in the proximal cap?
No, in the side branch.
Ah, okay, okay. Okay. So can we see dual injection in the other projection to understand a little bit more where is the proximal cap?
From this view, we can see by the bifurcation of the septal, you can see some blunt pre-camp. You can see
Okay.
here's our entry.
For everyone in the room, this is where they think the proximal cap is. It makes sense, in all honesty.
Yeah.
I'd love to see another projection, though. But
Yeah, well, I know.
This
But
is
from
fair enough.
yes, from the previous angel,
Okay.
you can see.
We have not the antegrade flow in this one, so I think antegrade flow will be very interesting also.
Okay. Because I reviewed the angel from several days ago, so I'm sure the entry point is the previous one. The entry point is just by the bifurcation of the septal. You can see some blunt entry point. So I'm sure here is an antegrade entry point.
We believe you.
Okay.
Yeah, I believe you because I can see nothing. So I need another projection for sure.
Yeah.
This one, we can suppose that the blunt cap is just up than your septal branch, but we are not sure.
Yeah.
Yeah, we just don't have the luxury to have seen everything like you. But yeah, dual injection in a different view, perhaps an AP cranial with a slight LEO projection, that might do. This is a right cranial. Yep.
Yeah. Perhaps maybe we can check it with Ivers.
But for the sake of demonstration for everyone in the room, because we really need to see both the proximal cap and distal cap simultaneously in two views.
Yes, because then we can decide the strategy, because here it's really difficult to say
yeah.
Is the proximal cap is clear or ambiguous. So for sure there is a beautiful retrograde option, but maybe we can start antegrade if the antegrade cap is clear.
Yes. So I agree with you. Next one. Next one. So I checked the collateral from the RC. I think maybe retrograde is a backup. First of all, we use XTA wire, but this wire cannot enter the CTO body. So next one.
声波球囊不是一种型号吗？
Next.
212吧。
This is a Gaia Sir. It's like more likely the wire go to the subintimal space. The next one, I change the wire to XTA. Okay. This wire in the subintimal space. So knuckle the XTA. Next one. Next. So I'm sure this wire is in the vessel construction, but in the subintimal. So how about next? Retrograde or stingray?
那他这个头子啊
Can we just have the previous cine, please?
Preview. This.
套过来，我们这边接，他那边套过来，打开了是。哎，他这个头子啊。
Those two with the knuckle. I would be very cautious to disrupt that area because that would make the retrograde options very, very difficult. Alex, you were saying something.
Yeah, so I think here I agree to there is no other option than ADR or retrograde. So then you need to choose between.
你把这个套到我们这边来，他们有人吗？他们懂不懂啊？
叫他们进来。
套进来。
叫他们进来。哎呀，我们自己这边灵彩我都没用过。对。
好，等一下。
Is to first go retro because I think now if you cross retrogradely the septal connection, your success rate will be very high, and you will not destroy the septal connection.
I agree with you very much. Let's see the previous.
前一张。
现在开机了没有？
接着进来，开机。
有一个闪通吗？
呀，最早的是吧？
Yeah.
双侧造影。
电子了。
From this view, you can see a diagonal just before the septal. So if we choose to single ADR, maybe we will lose the diagonal.
Exactly, for sure.
Yeah, so I think I agree with you. Retrograde is the first choice. If failed, but I agree. This subcollateral is possible or impossible. I don't know. It's very torturous, but maybe we need to just while it. If failed, maybe I will choose IVL guided re-entry, not the stingray ADR, because I want to preserve all the side branch. But retrograde is the first choice.
Sure.
Okay, so we try to the septal collateral.
继续。
With
继续。
to my surprise, we just use cyan blue. Next, previous. Okay, this is a cyan blue and Calville. I want to change it to cyan, but cyan blue is very easy to cross collateral. Next one. Okay, here's a tip injection of the Calville. You can see also a side branch. So next one. XTA cannot intro. So I changed to UV3. Also UV3 is failed. I changed to Gaia second, Gaia third.
Sure.
Next one. Then
Can I ask you a question?
Yeah.
Why at this stage you will not perform reverse cart?
What?
Why you did not perform reverse cart and try to cross retrogradely to true?
Reverse cart.
Oh.
Reverse cart.
I'm not really want to cross from retrograde. I just want to intro the retrograde camp because the Gaia third cannot entry. After the XTA, is the next one.
Professor Young, can I say that again slowly?
Yes. No.
Alex's question is, why are you trying to cross through to true retrograde rather than perform reverse cards?
No. I'm not trying to do true. I'm knowing that antegrade is in the subintimal space, definitely. So I just want to manipulate the retrograde wire to the same space. True lumen is okay, but false lumen is also okay. The next one, the retrograde XTA from the false lumen to the true lumen, proximal true lumen. You can see the XTA in the true lumen of the proximal and into the antegrade catheter.
Okay, so you are doing a reverse card now. That's great.
Yeah.
The retrograde wire is a bit too soft for that. That's still the XTA, right?
Yeah.
Okay. So perhaps an intermediate weight polymer jacketed wire would do the job. And I would have a low threshold for introducing a guide extension at this stage.
Deflation?
Dr. Chen,
16.
Dr. Xu from
Okay.
Fudan. Dr. Chen?
Hey.
Hey, Dr. Xu Zhaoyan.
Yeah.
Okay. Congratulate. I think that it's close to success. And I've asked questions that how about the AGR, AGT technique insert the Garcinia and to the side bunch and to the retrograde wire and punch to the AGT to the Garcinia. I think that is quite safe. Quite safe for if your retrograde wire punch to the false lumen, maybe the result is a disaster. So do you think that the AGT technique?
Agree. The AGT strategy is more effective, but in this case, I just want to try the retrograde wire. If the retrograde wire fail to enter the proximal true lumen, maybe I will insert Godzilla to the CTO body for the retrograde wire. But fortunately, I think the retrograde wire is go to the false lumen, and we have just dilated the CTO body with a 2-point balloon. We have do the reverse cut, so the retrograde wire go to the subintimal space and to the finally to the proximal true lumen. So maybe this strategy is fail. Maybe we will insert Godzilla. But in this case, the CTO body is too short, maybe 15 millimeter.
Hello,
Okay.
Dr. Chen. I'm Dr. Zhao from Xinqiao Hospital.
Okay.
Congratulations. I think it's almost the success. But if you, I think real-time errors in examination may be helpful for you to puncture.
For this question?
Yes.
Generally, if there is a side branch, maybe I will check with IVS. But for this case, I'm think the entry point is very clear. So,
I mean, you retrograde wire to avoid into the false illumination.
Of course, if the retrograde wire cannot go to the proximal true lumen, maybe I will check with IVS. I will check if the antegrade and retrograde wire is in the same space. But I think in this case, we will check with IVS. I think the CT body, the both wire, antegrade and retrograde wire, both in the fourth lumen. We will check with IVS later. Give me a double lumen caster.
RG3.
RG3.
Oh, my RG3.
Dr. Chen,
I
have another question. Is that I reviewed the images and I think that the distal of RCA or PDA, maybe the branch close to the epicardia. Do you think that before you choose the branch, before the T injection from the in the PDA, and avoid the perforation complication? Very close to the epicardia, I think.
Yeah. Maybe you need to manipulate the wire very carefully. I think maybe Xiang and or Su03 is safe, but like you see, maybe we need to very carefully because it's very close to the distal PDA. Maybe the first segment of the collateral is epicardial. So it's have some risk of perforation. So you need to very carefully. Okay.
You are good skilled and congratulations. And I will switch to another cabinet, and you do continue.
And ladies and gentlemen, please welcome Professor Yin Qiulin. We will transfer to Jiangxi Provincial People's Hospital, China, to deliver a case presentation on cutting balloon. Okay, let me introduce the clinical cases information from Jiangxi Provincial Hospital for all of you. And it is a male, 46 years old, requiring the back pain for more than 1 month. The patient suffered from sudden dull back pain without obvious inducement more than 1 month ago, lasting for several minutes to more than 10 minutes. The pain was aggravated by activity and relieved by rest. No fever, no cough, no expectoration, no acid reflux, or no heartburn. And the angiography finding, LM, no stenosis as ostium, and 50% to 60% segment stenosis in the body and distal segment. LAD, approximately 8% diffuse stenosis with calcification in the proximal and middle segment. Timmy flow grade 3, it's okay. LCX, approximately 70% diffuse stenosis in the middle segment, Timmy flow grade 2, and RCA, diffuse stenosis with calcification throughout the vessel. Approximately 98% diffuse stenosis near the trifurcation. So his past history was hypertension, coronary heart disease, history of PCI, and diagnosis would be coronary atherosclerotic heart disease, hypertension, type 2 diabetes. Next page, please. And the ECG finding, sign rhythm, roughly normal ECG. And ultrasound sonography, and first, mild mitral regurgitation, and second, mild tricuspid regurgitation. 3, decrease the left ventricular diastolic function. And LVF was 60%. And you can see the findings and at RCA, a target lesion located at the middle segment of RCA with severe calcification. Okay.
喂，尹主任，可以听到吗？
我可以听得到。
OK， 可以开始，可以开始。
好嘞，因为这个病人是一个全程的一个钙发，然后这个中段的话呢，有一个明显的一个钙发小结。我想因为这个 IVL 也过不去，来打起来，所以说我就想加一个延伸导管啊。
医主任，多德音，这里是会场，我想您能不能回放一下今天早上或者是手术前的一个照影
？OK。来回放这个照影吧。
回放一下。就是把那个右关的照影回放一下。
左关也放一下。把今天照影回放一下。这个病人他是一个三支血管严重钙发的病变。慢点，慢点，慢点，我左关也要看一下。
先看左关。
从第一幅开始。因为前降支的话呢，他在下面的医院的话，因为严重的狭窄，他已经先处理掉了，放了一个支架。OK， 下一个。我看这样的支架膨胀还可以，这个前降支的远端的话，虽然都是斑块，但是这块狭窄都还不算太重。下一个。
下一个。
支架到了左主干，对肺悬置的影响也不大。好，下一个。右关的话呢，我们看一下是一个非常扭曲的，然后一个狭窄，然后钙发。
RCA has a very tortuous lesions.
钙发狭窄最严重的地方应该是在地月弯以后，在后三叉前，大概95%以上的狭窄。钙化的话呢，好像看起来是全程的一个分布。我想下一个，我用2.0的胸腔扩完以后的话呢，就是说 IVL 跟不过去，远端的 IVL 的图像我看不到，所以说我只能到达地月弯以后，我看了一下 IVL 的图像。在地月弯之前的话呢，有个明显的一个钙发小结，而且的话呢，有个270度的一个钙发，因为血管的沉角，然后加上这个钙发，远端的话呢，我想先去用 shockwave， 就这个冲击波球囊先看能不能把它这个钙发把它打开一下。现在的话呢，我这个我刚才试了一下，好像我想把这延伸导管插过去，稍微是有点困难。但会场上有没有什么更好的办法？是不是我先把那个钙发小结先冲击波先扩开啊再说？OK， 把冲击波过来。对，这里看看那个右关的中道啊，好像我这里就过不去。我现在冲击波冲完以后应该过得去。
The blue cannot cross the middle lesion of RCA before the heavy calcium and with the calcium noodle. So every catheter, all the catheter cannot cross. So how about the strategy?
医生有没有考虑过这个先进行rota？
我当然考虑过这个问题，因为第一个的话，它这个钙发压的主要是在远端，而且我的话，我已经第一次扩张完了以后的话，就是说在月光的中段已经有夹层了，所以说的话呢，就是说我像 rota 的话，可能会造成非常严重的一个撕裂，非常严重的夹层。我现在这个下会这个冲击波球呢已经到了远端了，我现在从这里开始震起来。OK， 打4个大气。
Right now we're using shock fast.
现在开始在进行冲击波治疗。
Our shock fast delivers 10% smaller crossing profile, and it cuts shock time by 34%, 3 line per start, with burst pressure up to 25 MSVA. It offers unmatched reliability, and its intuitive, easy application that simplifies the clinical flow. Its size ranges from 2.5 to 4 millimeter diameters, with 2 lengths, 12 and 15 millimeter working lengths. The catheter features 2 radial black markers for precise placement, and 2 emitter delivers 120 pulses of target. Now we are using the IVL.
你把这个转给我看一下吗？打了6个大气。
How about the diameter? 这个how about the diameter? About the shock fast
lesions.
How about the blue? 医生，那个球囊有多大？
这是2.5的球囊。
选择哪一个直径？
因为我看远端的，iOS 看远端的就是2.5到2.75，我选择了个2.5的这个冲击波球囊的4个大气。我看到这球囊已经起来了哈，等一下来打了6个大气，8个。OK，
能够完全起来吗？这个球囊，
可以完全起来。
那个没有腰吗？
没有，这里看得到啊。
因为我这里的
看不到吗？
清晰，我们这里的影像不太清晰，主要是很模糊。
哦，
是，
可以起来。打了8个大气。
刚开始的时候。
开始一个明显的腰，最后的话，我们经过冲击波治疗以后，它腰就消失了。
The calcification has already been cracked.
你是扩张了2个段是吧？2个就是那个远端一个段，现在是一个段是吧？
对。因为它总共有8次。
3个循环钙化凝聚。
Now we have already applied 3 circles, and the calcification has already been cracked.
那医生，我想问一下，下一步如果是冲击波做完之后，下一步的策略是什么？是用切割球囊，还是用高压球囊来这个预处理？
What will be the next strategy Dr. Yin Qiulin will be applied? Maybe carting balloon or the ultra high pressure balloon?
我想这个2个球囊都可以。从 iOS 上来看的话呢，因为它只是个钙发，这里主要是个钙发小节为主中档，所以说我想用高压球囊就扩了。但近端的话呢，因为我这里看的好像钙发的不是很厚，比较薄，所以说我就近端的想用一个切割球囊去进行 cut balloon 去切一下。
那这个切割的话，这个尺寸是跟那个震波这个冲击波是同一个 size 是吧？因
为我要对近端进行切割，我那可能 size 可能会大一点了。 我可能会选择2.75或者3.0的切割球了，因为它近端的直径的话，至少有3.0。
So the Dr. E will apply the cutting balloon at the middle segment, at the proximal segment, and the ultra high pressure balloon will be applied at the distal segment.
2.5的后扩球囊。
到这里以后的话呢，我就想先把远端的支架我先放好，放好的话呢，我再来处理近中段了。帮我拿一个2.5的长支架过来。2.533的支架。
So now we are applying 2.5 millimeter and 33 stand. Apply in the middle segment of calcified lesions.
您觉得放支架前有没有考虑把这个延长导管尽量送远一点？因为虽然是预处理过，但是可能支架。
对，我也是这样想的。看是那个后扩球囊的话呢，因为我塞进去以后，它血压这个压力就没了，所以我想塞的时间尽量短一点，我把远端先扩张一下的 ，OK。最后我把它塞进去，这个延长导管再插远一点，这样的话可能缺血时间会短。来，这里打起。
Now we are trying to apply the guide extension catheter to longer distal segment.
我现在延长导管已经插进去了啊，但是它的压力马上就下来了。来，把支架拿过来。
Now the guiding extension catheter has already been applied. Now we are ready to put in the stent.
这个支架是放到这个一个比较宽的地方，我看到后三叉前好像有一个比较宽的地方。
对，这里有个落脚点。你看支架现在很容易通过了。OK 是吧
？After the pre-treatment of the doctor, the stent is going through smoothly.
我看看。有一点。还要再往前走一点点。
And now I'm going to introduce some part on our short fast ultra. It got a longer size ranging, from 2.0 to 5.0 millimeter, and we got much more length. It's 20 millimeter, with 3 emitters for long lesions, and we have reached to 240 pulses for this ultra version.
20。15个。
您觉得打了多大的压力？
我打了15个大气啊。
OK。
产品。
对钙发的血管，我认为还是高压释放。
那下一步是还预处理这个中段这个病变吗？
中端我已经冲击波已经治疗过了，我等近端最后我再拿个卡里布隆我再去切一下。我想因为这个中端已经严重的夹层了，我想 先把中端的支架先放掉，
对，
再来个3.033的支架。对，所以说，因为这个艾沃斯看这个近中段是全是斑块负荷挺重的，所以说我想这个所有的都拿支架进行接起来了。所以说预计这个用完要3个支架。那再帮我准备一个3.0的 cut balloon 切割球呢
3.0切割。
Now we are trying to apply 3.0 millimeter diameter cutting balloon.
我看这个支管是有了这个延长导管，还是血压还是挺稳定的啊，还是挺。
这个延长导管，因为它是一个带侧孔的，那侧孔的话，可能就是还是能提供的，但是，你插远了以后的话呢，它这个压力是来自于这个母管，就来自这个来自这个盖顶，但是冠脉里面有没有灌注，现在也不好说了，因为我这个盖顶它已经离开了这个冠脉口。 能给我来个支架模式吗？不是，他那个有，他那边有啊。给他支架模式吗？
他们有切割。
给了蛮多。蛮多。 OK， 刚刚介绍吗？要进去一点点啊。啊，这里可以。而且。
打哈。
是80。10.44。OK。就行了。 这就可以。OK， 可以拉过来。
印主任还有个问题，就是放完支架之后，是先后扩张呢，还是这个先看一遍 IVS？ 才决定这个后扩张的一个球量大小啊，这个位置啊，这样的一个策略。
So what's the next strategy will be applied? Like we using cutting balloon first, or we check the IVL first?
要根据不同的病变，因为这个病人他全程支架，而且从支架的形态上来看的话，起的不是太理想。 所以往往这种情况，我会先去后扩张，然后再去看 IVS。如果说你对一些病变不是那么长，也不是那么复杂的话呢，可以先去看 IVS 看看。特别是对一些短的病变。OK，
To this case, we will trying to do the post treatment, use the NC balloon first. Yeah. 李主任，我们现在现场要切回其他医院了。
OK，
All right, ladies and gentlemen, we are now going back to demonstration 9 from the cath lab of Shan First People Hospital.
哦，来了。
We get back to Professor Dr. Chen Yong.
Hey, hi.
Hey, we back again, Dr. Chen.
Yeah.
OK.
陈勇老师，麻烦您这边做一下总结 ，review 一下我们。
你是先扩完。
行吧，我们先
讲完。
对。
Pro
支架模式我看看。
Reviews。
从
Reviews。
就差不多这里了。就我们做了。
OK，
体外化，对吧？我们就。
We just leave here.
我把这个耳麦拿。
Let us see the IVS first.
，Iris 能转播过去吗？啊
Yeah, we
Do you
can.
see the
再
iris?
加10，这个
Yeah,
23，
we can see.
Okay, the final Qiulin.
来个3.523，
Yeah.
Some bubble. We can see some hematoma,
Yeah.
but this hematoma is limited to just around the septal.
Intima.
有2个吗？
Qiulin
Yeah, is in the park.
The other one is retrograde RG3. So the vial is
拿过这个弯就可以。
in the plaque all the
Yeah.
time.
So, do you think that the local, the effect of local, is it equal to the reverse cut?
I think maybe the proximal segment, the knuckle XTA is in the black, but maybe beneath the out point, go to the subintimal space. So you can see some hematoma, but limited to the septal. 把那个 iris 再到那个血肿那一段，再给我们看一下。The hematoma is very short.
Yeah.
Here is a low hematoma. So I think maybe here the knuckle vial is go to the subintimal space. So in this case, if retrograde vial, maybe iris guided re-entry is very promising.
拉到2.5的后后来。
Do you agree?
Yeah.
这个是那个，这个是3.0的，它指甲没坏。
The segment about the segment of hematoma about 10 to 50 millimeters.
No.
Maybe
No.
only 5.
Maybe. Yeah, maybe it's very limited. Maybe only 5 millimeters.
Yeah.
Just beyond the septal branch.
Yeah, it's very efficiency.
So anyway, we put 2 stents. This is the final angle. All the branch is preserved. So I think it's I'm good with this result.
经常来了，把眼睛
Feel good.
Okay.
等等。
How about total minutes do you cost? So about 1 hour or more?
16、10、12、14、
What?
16、18、20。
Total procedure time.
Is 29 minutes X-ray time.
The procedure time. The
procedure time
1.5 hour.
手术的时间总共手术
1 hour and a half, maybe.
1 hour and a half. Okay. Okay.
So I think
Congratulations.
for this question, maybe the retrograde is to our surprise is simple. So I think maybe retrograde
16、20。
result. like this case.
Yeah.
Okay, thank you.
I think so. TD ADL may be the advanced skill, and maybe we learn from you.
Okay, thank you.
Thank you.
Okay, let's now move on to the next presentation by Professor Dr. Zhao Xiaohui. Please welcome.
Good morning, everyone. Okay. Good morning, everyone. My topic today is a novel coronary bifurcation classification. My topic is divided into 3 parts. First, classification of bifurcation lesions. Second, the jaw classification. Third, clinical evaluation. Part 1. The definition of bifurcation lesions, as we all know, is defined as a coronary stenosis adjacent and or involving an adequate sized side branch. However, as we know, the CTO is a very interesting procedure. It's like a quiet little dog, thoroughly doesn't bite, and as long as you perform it properly. But bifurcations are different. They are like your girlfriends. You meet them every day, but they are difficult to handle. Also, they will complex and sometimes with poor prognosis. The challenge is there are so many types of bifurcation lesions, even though there is only one additional side branch. So we need to do a lot of work or study to compare, to get the right treatment. So we need simple and effective classifications, easy to remember, to capture the detailed morphology. There are many types of classifications, 1, 2, 3, 4, 7, blah, blah, blah. But many of them are difficult to remember, like this one, Duke. And however, the Mediner classification are popular and recommended by the EBC and the guideline. According to the sequence of the proximal main vessel, distal main vessel, and the side branch, stenosis more than 50% is recorded as 1, and a stenosis rate less than 50% is recorded as 0. It is direct description, but is semi-quantitative. Also, Mubahid is a US doctor, also proposed classification in 2006. Dr. Chen in China also have his named classification. In 2024, we, according to, based on the Mediner and Mubahid classification, we we developed a 3M classification, but it's a little bit complex, so we improved it. We call the jaw classification. There are 3 parts of the classification. The first is location. We use the L as the left main vessel. The second part is the bifurcation angle. We use the T as the angles more than 70 degrees. Y as MV 90% stenosis, SB 80% stenosis. So we need 2 student technique maybe. The advantage, the first is simple for memorize. Left main use the L. The TY routinely used for TY stenting technique. Also, the 2 numbers is similar with the Mediner format, but is more specific. The second is the quantitative, so we can see the picture when we see the classification. It's very helpful. The part 3 is the clinical evaluation. There are 9 centers, 24,000, more than 24,000 CAJ patients was examined. Altogether, there are 17 obstructive coronary artery disease patients with 15,000 lesions were included and analyzed. First, of these patients, 41.4% had bifurcation lesions. It's much more than we thought. It's so popular in our daily work. The bifurcation lesions accounted for 18.4% of total lesions. The bifurcation intervention accounted for almost 21% of the total PCI procedure. The distribution of bifurcation lesions is interesting because we can see almost 90% of left main lesions are bifurcation. Also, 60% of left main bifurcations are T-type. 70% of non-left main bifurcations are Y-type. So it's useful for our daily knowledge. Second, guidance for procedure strategies. For example, a Y55 means we just need medicine. But LY55 means left main bifurcation. MV 50% stenosis, we maybe a single stent strategy is suitable. But for LY99 with significant stenosis in left main, so we need a double stent strategy. So we can see怎么停止这个暂停？有没有鼠标？ Case 1 is non-STEMI. The classification is LT99, so it's a very serious condition. We use the ECMO to support, and two stenting technique is used. Next one, yes, the right coronary is occluded. The case 2 is also a non-STEMI with a trifurcation, LT992. So a two stent technique is used. The case 3 is acute myocardial infarction with cardiogenic shock. We use ABP. His non-left main lesions with the side branch stenosis is 30%. So we use the one stent cross over the diagonals. In our study, we found in left main bifurcations, 87.2% cases with main vessel stenosis more than 50% underwent PCI. In non-left main bifurcations, 84% underwent PCI. However, the Medina classification only 64% were treated with PCI. So the draw classification is much better in this section. 3, prediction of side branch compromise. There are a total of 1,946 bifurcation lesions and 1,893 patients were analyzed. SB compromise occurred in 199 lesions. We found that the location, the Angela, main vessel and side branch stenosis were significant predictors of side branch compromise. A prediction model for side branch compromise was established also. The AUC values of visual model and the QCA model were similar. The value is high. Also, we use the external validation with an independent data set with 600 patients. Also show the favorable effect. Also, we use the resolve score reported in 10 years, which is Dr. Doe's study. So the result is similar, but their score have 6 parameters is complex than us. Also, we use the Medina to analyze, and we found that the Medina classification has no predictive value for set branch compromise.